I've been given an important and a fascinating topic. A lot of people are fascinated by the brain tumors, and but there's a lot of controversy regarding its outcome. So I would like to share that if intervened timely, they have a good prognosis. So I'll be starting my presentation. Bismillah. I do not have any disclosures to make. So first of all, the gross anatomy of the brain. So I would, first of all, I will start with the anatomy of the brain. As you can see in this picture, this is a frontal lobe in the brain, then the parietal lobe, the temporal lobe, and the occipital lobes can be seen in the picture. And coming to histology, types of the cells in the brain. Here you can see astrocytes. These are basically the physical and metabolic support cells of the brain and important in formation of the blood-brain barrier. Then come the oligodendrocytes. Basically, these are responsible for the formation of myelin in the CNS. Ependymal cells, these can be seen over here. These line the ventricles, and the Schwann cells are basically the myelinating cells of the peripheral nervous system. Now coming to the brain tumors classification, the tumors are classified as tumors of neuroepithelial tissue, tumors of the cranial and the peripheral paraspinal nerves, tumors of the meninges, lymphomas and hematopoietic neoplasms, germ cell tumors, tumors of the cellular region, and metastatic tumors. So coming to the general presentation of the brain tumors, usually the most patient with the brain tumors present with progressive neurological deficit present in 70% of the cases. Headache is common, and seizures are present in 25% of the cases presenting to us with tumors. The focal neurological deficit related to the lobes are as following. The frontal lobe tumors usually present with dementia, personality changes, hemiparesis, or dysphagia may occur if they involve the left or the dominant lobe. Temporal lobe tumor patients present with auditory and olfactory hallucinations and memory impairment. Parietal lobe patients present with sensory impairment, homonymous heminopsia. Occipital lobe patients present with contralateral visual field deficits, and the posterior fossa lesions present with cranial nerve deficits and ataxia. So coming to a very brief discussion about the different types of tumors, coming to the astrocytic tumors, these are the most common primary intraaxial brain tumors. These typically arise in the white matter and traverse through the white matter tracts. Pilocytic astrocytoma being the most common in the children, and the glioblastoma being the most common in the adults. So how they spread? They may spread by following mechanisms such as the tracking through the white matter, CSF pathways, and rarely they metastasize or spread systemically. So this is a picture, MRI of the brain showing butterfly glioma that is involving both the hemispheres of the brain. Coming to the ependymal tumors, they may occur anywhere along the neuroaxis. In pediatrics, these are most common in the posterior fossa, and in the adults, they tend to be intraspinal. In 11% of the cases, drop mets are present. Intracranial ependyomas usually are benign, most often in the floor of the fourth ventricle, present with hydrocephalus and cranial nerve 6 and 7th palsies. Evaluation requires MRI of the entire neuroaxis. The worst prognosis in the patients who are less than 24 months of age. So this is an MRI of the brain, tumor in the fourth ventricle, and expanding the fourth ventricle and resulting in the hydrocephalus. Coming to the embryonal tumors, retinoblastoma, paneloblastoma, neuroblastoma, medulloblastoma are the various forms. Coming to medulloblastoma, in children, these constitute 15 to 20% of the intracranial tumors and 30 to 55% of the posterior fossa tumors. These are most common pediatric malignant brain tumors, and a preponderance of male to female ratio that is 2 to 1. 10 to 35% have seeded the craniospinal axis at the time of the diagnosis, and extraneural mets are present in 5% of the patients. In these kinds of patients, shunting is not indicated because this may promote the extraneural mets. So this is an MRI T1 contrast showing the pedulloblastoma resulting in development of a hydrocephalus. Now coming to the vestibular schwannomas, basically one of the most common intracranial tumors, 95% of these are unilateral. The incidence is increased in neurofibromatosis. Bilateral vestibular schwannoma is pathognomic for the neurofibromatosis type 2. Any patient with age less than 40 years with unilateral vestibular schwannoma should be evaluated for neurofibromatosis type 2. Clinical picture is closely related with the tumor size. Usually most of the patients present with the clinical triad of ipsilateral sensorineural hearing loss, tinnitus, and balance difficulties. Large tumors can cause facial numbness, twitching, or weakness of the face and brainstem symptoms. Large tumors may also produce hydrocephalus. So this is a picture, T1 contrast MRI brain showing a vestibular schwannoma that is ice cream shaped, cone ice cream shaped, and its extension into the internal acoustic meatus. Coming to the meningiomas, so basically these arise from the arachnoid layer of the meninges, and these may be present at any place where the dura is or meninges are present. So here you can see the parasagittal, olfactory groove, suprasellar, clival, foramen magnum meningiomas, and the cerebellar meningiomas. So these are the most common primary intracranial tumors. These are usually slow growing, circumscribed, and benign lesions, and may occur anywhere in the brain. Mostly are asymptomatic unless the size increases and causes the mass effect. Meningiomas account for 14.3 to 19% of the primary intracranial neoplasms. Incidence peaks at 45 years of age. Female ratio is 1.82. Female to male ratio is 1.8 to 1. 19 to 25% of adolescent meningiomas occur in patients with neurofibromatosis type 1. It is also known as von Reckling-Gazens disease. So now, just an overview of the locations. Most common are the parasagittal ones, then the convexity meningiomas, and then the tuberculum cellae meningiomas. So this is an MRI T1 contrast enhanced image of the parasagittal parafalcine meningioma. Also an MRI T1 contrast of the parafalcine meningioma, falcine meningioma. This one is a T1 contrast image of the olfactory groove meningioma. So now coming to the pituitary tumors, most pituitary tumors are benign adenomas arising from anterior pituitary gland, that is known as the adenohypophysis. These can be endocrine active or inactive tumors. So the tumors less than 1 centimeter diameter are known as microadenomas, whereas the tumors larger than 1 centimeter diameter are macroadenomas. Presentations can be due to too much hormone production, to less hormone production, and mass effects. So just an overview of the hormonal production. If there is too much prolactin, it can cause amenorrhea and galactorrhea in the females, impotence and gynecomastia in the males. Growth hormone in adults causes acromegaly, and in the prepubertal children may produce pituitary gigantism. ACTH abnormal secretion can cause Cushing's disease or Nelson syndrome if patient has already have adrenalectomy. Increased TSH secretion may result in secondary hyperthyroidism, and usually the gonadotropin, those are the LH and the FSH overproduction, does not produce a clinical syndrome. Second presentation, type of presentation can be due to the mass effect. If they are compressing optic chiasm, may result in bitemporal heminopsia. Involvement of third ventricle may result in obstructive hydrocephalus. And if these invade the cavernous sinus, may result in the picture of third, fourth, trigeminal first, second branches, and the sixth nerve involvement. So this is a basically MRI T1 contrast enhanced image of the pituitary adenoma. There is a macroadenoma and extending into the third ventricle. Also, these are can be here seen that these are compressing on the optic chiasm over here, and also involving the carotid bilaterally. Now come the metastasis. Most common brain tumors seen clinically, comprising slightly more than half of the brain tumors. 15 to 30% of the patients with cancer develop cerebral metastasis. May occur in 6% of the pediatric cancers, and route of spread to the brain is usually hematogenous. And lung and breast carcinoma account for more than 50% of adult cerebral metastasis. Location of METs, the highest incidence of parenchymal METs is 75%, that is 75% is posterior to the sylvian fissure near the junction of temporal, parietal, and occipital lobes, mainly due to the supply via the NCA, which is a direct continuation of the internal carotid artery. So the METs are directly transported to these regions. The cerebellum is a common site of intracranial METs, and the location is the location in 16% of the cases. A solitary lesion in the posterior fossa of an adult is considered a metastasis until proven otherwise. So here you can see an MRI of the posterior fossa metastasis. Also, there are multiple metastasis. Those are supratentorial. A solitary lesion, metastatic lesion. Now, coming to the tumors of the spine, these can be compartment localization of the spinal tumors is number one, the extradural tumors. These constitute 55% of spinal tumors, and these can be located to the vertebral bodies or the epidural tissues. Then are the intradural extramedullary tumors. These constitute 40% of the spinal tumors, arise in leptomeninges and roots, and most common are the neurofibromas and the meningiomas. Rest of the 5% are constituted by the intramedullary spinal tumors, most common being astrocytomas, ependymomas, and then there are rest of the tumors. Types of the tumors of the spine, that is the bony spine, can be metastatic or the primary spinal tumors. Benign being vertebral hemangioma, osteoma, osteoblastoma, aneurysmal bone cyst, osteochondroma, giant cell tumors of the bone, and malignant being the chondrosarcoma, chordomas, and osteogenic sarcomas. Those are rare. Metastatic lesions can be osteolytic or osteoblastic. Osteolytic being lung, breast, prostate, lymphoma, plasmacytoma, whereas the osteoblastic ones in the male are the prostate carcinoma, whereas in the female are the breast carcinoma. So basically, these are both osteoblastic and the osteoclastic at the same time. Symptoms and signs presenting with the spinal tumors are back pain, which may be followed by radicular pain, either unilaterally or bilaterally. Myelopathy at a later stage develops. Gait disturbances might or might not be present, and lesions at the conus level are usually associated with early sphincter involvements. So basically, some of the modalities that can be used to image the neural tumors. First one is the X-rays. These only will show the bony involvements. Then the CT scan, this may show the bony involvements as well as with contrast can be used to see the intraparenchymal lesions. Then comes the MRI. It is the modality of choice for evaluating the lesions in the brain and the spinal cord. That is the soft tissue is best imagined on the MRI. Best imaged on the MRI with contrast, more preferably. Then there is an angiography option that is only used to evaluate the vascular lesions or the feeding of the lesions that are very much vascular. The systemic workup, a whole CT, whole body CT scan can be done if suspected metastasis. Craniospinal contrast MRIs can be done for systemic workup, and the bone scan if the tumor are suspected to be of bony origin. So now coming to the adjuncts to the neurological surgery, which we routinely or sometimes use during our neurological surgery. First one is the intraoperative neurological monitoring. Second one is the neuronavigation for deep-seated lesions. And third one is the surgical microscope for very fine dissection and very fine tumor removal, as well as other neurosurgical procedures. Another modality is ultrasonic aspiration that gives good tumor resection while remaining inside the tumor margins. Somatosensory evoke potentials, motor evoke potentials, intraoperative ultrasound, intraoperative CT, and MRI spine are other modalities that can be used for safe neurosurgical procedures. So now, another important thing that is basically we have started doing at Shifa, that is the awake craniotomy, and is indicated for the tumors involving the eloquent areas of the brain. There is a small video showing surgery for a patient that had an eloquent tumor area or tumor involvement.
शिफा इंटरनेशनल अस्पताल इस्लामाबाद, उम्मीद और जिंदगी के सफर में आपके हम कदम।
There you can see the left side which area is involved by the tumor, and it is basically awake during the surgery, and we are just working the tumor safely as much as possible. He's moving his hands. So this is the post-operative video with no neurological deficits.
बिल्कुल एग्जैक्ट बना लेते हैं जिसकी वजह से दे देते हैं मरीज को ऑपरेशन के दौरान रसोली में चली वाला पार्ट डिफरेंट.
So other new modalities which are being used in the radiosurgery are the gamma knife. Basically, these constitute the stereotactic radiosurgery, is a non-surgical radiation therapy that is used to treat functional abnormalities and small tumors in the brain. These can deliver precisely targeted radiation in the fewer high dose treatments than the traditional therapy, hence preserving the healthy tissues. So there are two types, gamma knife and cyber knife. So combination of traditional radiation and chemotherapy is also used, and it is helpful in reducing the tumor load and preventing the disease recurrence. So basically the management goals of the neurosurgical tumors are early surgical intervention to prevent further neurological deterioration, a good functional outcome, reduce the morbidity and mortality, pain relief, and in the last but not the least is the preservation of the spinal stability of the tumors involving the spine. Thank you very much.